I do want to talk next really about the concept that Alan brought forward is this sort of radioembolization approach. And you know, this field to me has evolved. It went from bland embolization to chemoembolization to DBRI, which is sort of chemoembolization, and you know, pumps, intrahepatic pumps, and now we're sort of at the next version of that is intrahepatic delivery of radiation. And Johanna, I'm going to pick on you to sort of set the stage around this technology a little bit and the studies that were done to help support it.
Yeah, so we're talking about Y90 treatment. The way I describe it to my patients is they're microbeads that are coated in radiation therapy that are injected directly in the liver and are carried directly to the tumors within the liver, preferentially because of the blood flow patterns. And so we've seen in earlier studies in more refractory patients that when you inject the yttrium-90 beads, that you do get significant shrinkage of the tumors within the liver. And so can we use this earlier on? So previously this was used mostly in a more refractory setting. But the SURFLOX study that presented some recent data looked at it in the first-line setting using FOLFOX-based first-line chemotherapy and randomizing patients to chemotherapy alone versus chemotherapy plus the use of the yttrium Y90 beads.
And right from the beginning, you know, right at the beginning,
And so what they saw is they saw not a difference in progression-free survival overall, because about 40% of those patients had extrahepatic disease. But certainly within the liver, they saw a significant improvement in response rate in the liver disease using the Y90. And then also they saw a improved progression-free survival for the liver-specific disease using the Y90. And so we're hoping to see more data come as more studies start to read out using this type of therapy for these patients.
So yeah, this study has really had an influence on me. I mean, I think the liver number is like 20 months of liver disease control. And I think about a frontline patient with liver dominant or liver only disease. I'm actually using that number in clinic with patients. But I have to say, I'm not following that algorithm. I mean, I'm tending, if I'm going to do this, to do it as sort of a pre-maintenance or part of the maintenance. And I don't have a lot of evidence to do that. But I just wondered, Tony, let me pick on you on this one. Are you doing any of this? Is there a patient where you might say this is an ideal patient, others that you might not?
So I agree. I haven't adopted it as per the study because, again, waiting the results of the survival data that was overall negative study, although it had some positive endpoint, a secondary endpoint. But in actual practice, when you think about it, so I've had instances where patients adamantly had disease limited to the liver, adamantly refused to continue on chemotherapy after a good response to chemo. And I've used it as a maintenance strategy in select patients that refuse to actually go on further chemo, capecitabine plus Bev. And actually, you know, as long as the disease has been very well controlled with chemo to a minimal residual component, this actually has been, for few patients, a good modality. The other place is actually in patients who have failed a couple of lines of therapy and do not want to go on any further systemic therapy and disease is still limited to the liver. I found that useful. I mean, these are the two instances where I've used it.
Yeah, I've been stronger than that because it seems to me to be relatively well tolerated, fairly simple to deliver. If it's bulky liver disease, I'm trying to fit it in earlier, not necessarily that. Don't get me wrong, I still use a lot in refractory and depending on how they're doing. Alan, I know you you're very data driven and your practice really is driven by what's out there. What's going on?
So we're studying the modality. I mean, we've typically used it later line. I think the SURFLOX study, which was very well done, I think leads me to believe it may have a role up front, depending on the results of a few other studies the results of which will be pooled. Where we tend to use it early is there's a subset of patients who can't tolerate chemotherapy. You can't get their platelets or their white cells, you just can't get much in. And those are patients I might very well early, it's clear to me after a cycle or two that they're just not going to tolerate aggressive chemotherapy for very long, I might jump in early to try to at least manage the liver involvement right off the bat.
And bulkier disease maybe, not a great initial response.
Correct. That's where we tend to go with that. And again, it is in our hands well tolerated. It's not a simple procedure. It's a multi-phase procedure. You need 2 visits to the interventional suite. That they need to map the disease, see what the shunt fraction is of the beads going away from the liver. It's not inexpensive, but again, I find you get a lot of bang for your buck in those patients.
And sometimes they're coming back and doing a second. They're doing one lobe.
Yeah.
I mean, this study was, I think, a single injection.
Correct.
And now they're doing more and more.
Correct. And again, the issue in the study, 40% of the patients had extrahepatic disease, and the benefit was much less notable in that population. So I do believe patients with any volume of disease outside of the liver, this is not a very great play unless there's a huge volume in the liver where you're worried about liver progression and failure early on. So we use it, we're moving more and more towards this, and again, I'm very waiting for the definitive results from the survival data to see if that is really a benefit. Then in fact, I think it will have a place earlier in many of our algorithms.
I tell my patients sort of fatigue, sometimes lasting a few weeks, but many have very few side effects, sometimes the pain and nausea, but it's an outpatient procedure. It's not embolic, right? It's so you don't have that same sort of acute pain and nausea that you see with embolization. Anybody throw in other things?
The only one thing I would say is I have had some patients present with gastric pain, epigastric pain afterwards, and you have to have a very low threshold to make sure no ulcer occurred. And that would be the only thing that I wouldn't want somebody to miss.